Now over to Dr. Nandi.
Yeah,
Please.
good to see many people attending this session at this point of time. Till now the discussion was how many injection to be given and when to be given and how effective is the injection. Now I am talking little different. I am saying about when to stop, not to give injection. So injection is the mainstay of treatment for a lot of medical retinal disorders like CNVM, PCV, DMO, RVOs, and others also in some cases of neovascular glaucoma, cyst or macular edema following cataract surgery, which is not responding to the drops. So the most important point is the cost involved in these cases. So these are the trials, landmark trials, which saying there's a burden of injection in 5 years, 12, 24, 7, 12 to 15. These are the number of injection patient need to take in 5 years time. So very difficult to sustain or continue the injection in real world situation. And there are a lot of unsolved problem. Even though we give injection, we cannot treat the ischemic maculopathy. We cannot treat non-responder, what madam has already shown. And whether to give monthly injection or PRN, that is a big question because in Indian scenario, monthly injection, many patient doesn't receive monthly injection. They come for PRN and even we treat the PRN. And residual edema, even if you can see the macula, the fovea is flat, you can see the peripheral edema persisting parafoveal region. Those patients is very difficult to treat, whether to treat those patients or not, very difficult judgment. So when to stop? First I'm coming to neovascular AMD, the CNVM. So there are a lot of types of scarring in CNVM that happens. These are the scarring pattern where the loss of photoreceptor and here the well-maintained photoreceptor. This is the important point. The photoreceptor well-maintained, even though patient has received multiple injection, the visual acuity of this patient must be good than the above one. And this is totally scarred, the thin fovea. There is a subretinal hyperreflective material accumulating at the center. So these two patients having very poor vision. So degenerative cyst, you have to identify the differentiation between the cyst and macular edema and the outer retinal tubule. Outer retinal tubule are cyst-like spaces oriented above the scar and it is about the outer nuclear layer. This is the outer retinal tubule. This is not actually the cystic edema. So this patient is not going to respond well to the anti-VEGF. Here we can stop giving injection. This is another picture of outer retinal tubule. This is the photoreceptor reorientation above the area of the scar. So these you have to differentiate between the cyst and macular edema and outer retinal tubule. I'll demonstrate a case. This is a 65-year-old female with a sudden loss of vision in the left eye. This is see the lot of outer retinal tubule. There's a subretinal fluid, some area of cystic spaces. So this is a chronic case. Patient was suffering from chronically and patient didn't turn up about treatment because of the COVID situation at that point of time. But still we offer treatment and after giving one injection, everything resolved. But you can see there's a huge area of subretinal hyperreflective material is still there. So here we may not inject further. We can stop giving injection to this patient. The case 2 is a RAP lesion. You can see there's a RAP, multiple area of subretinal fluid and there's a scarring already going on. The patient is late to present to us. Even if the injection with PDT gives a scarring, but vision has improved a little. Case 3, you can see the area of scarring at the center and huge hard exudate surrounding it. And you can see there's a cystoid degeneration along with the central scar. So how much vision the patient will improve after giving injection? So here we may not give injection to this patient. So stop giving injection in a CNVM when you can notice the outer retinal tubule, where you can see the scarring at the foveal area, when you can find the cystoid degeneration rather than cystoid macular edema. Now going to DME and RVO, there are few markers which are available in the literature. Like first is the disorganized retinal inner layer, where you cannot identify the retinal inner layer properly. These cases, even if we give injection, does not do well after giving injection. This is a case demonstration. This is a 54-year-old female. You can see there's edema, but there's a rip at the outer retinal layer. This is not the RP rip. There's a rip at the outer retinal layer. So even the vision is counting finger 2 meter. So even if we give injection, the vision recovery will not be great. You can see the cystoedema is reduced. The rip is still persisting. So you can keep on giving injection, but how long? You have to stop here. And we have to notice the combined lesion. We have to identify the combined lesion. Not only RBO, the patient is also having the arterial occlusion component here. So in case of arterial occlusion component, the patient is not going to do well with injection. You have to treat the basic pathology. So you have to notice our combined occlusion and peripheral non-perfusion and ischemic macula. After giving multiple injections, the macula is ischemic, we cannot treat. Previously also demonstrated if there is a ERM or the vitreomacular traction itself can cause deterioration of edema, non-resolving edema after giving multiple injection. Here you can see there is a ERM formation, which is the cause of this edema is not getting resolved after multiple injection. And another, after giving in CRBO, mostly in CRBO, the patient after receiving multiple injection can result in development of lamellar macular hole with ERM formation. Multiple injection itself can cause ERM formation. So here we have to stop. This is another case demonstration, case 4, diabetic patient. There is a edema here and see the area. Mostly all other vessels are sclerosed. FFA shows there is a non-perfusion foveal area. Even the patient received PRP laser, the fovea is still ischemic. And another important thing is a hyper-reflective crystal deposition at the central of the fovea is another indication where you need to stop giving injection. OCT features helpful when you can see there is a breakdown of the outer retinal layer and there you have to stop. So the main feature is the drill, the cholesterol crystal deposition, epiretinal external limiting membrane, ellipsoid zone degradation or discontinuity, ERM formation, large cyst. These are the poor prognostic indicator where you have to stop giving injection. And if you say the vision, yes, definitely vision is a criteria. If the vision gain is less than 5 ETDRS later and CST reduction is less than 10% from the baseline after receiving 3 consecutive injection, then either you can shift or you can stop giving injection. Thank you. And any question?
Thank you, Dr. Nandi. Very